Good morning, everyone. I am Dr. Joshua from the Department of Surgery. I am presenting clinical granulums from the Department of Surgery. Miss G, 22-year-old female patient, unmarried female, resident of Western UP, admitted to our Department of Surgery on 26th August 2022. Her presenting complaints were enlargement of the bilateral breast with swelling in the left axilla. History of present illness: there is bilateral enlargement of breast for 2 years, which was initially there was a sudden increase in size followed by gradual increase over the 2 years, and initially it is associated with pain, fever and reddish discoloration. There is skin excoriation with bleeding for 2 months from the left axillary swelling, and she is unable to perform her daily activities due to the enlargement of the breast. Past medical history: patient was evaluated in AIIMS Delhi and she was diagnosed to have bilateral breast hypertrophy and planned for surgery there, but she presented to AIIMS Rishikesh due to long waiting. She could not get operated and her disability began to increase. Menstrual history is her cycles were regular, normal flow and duration. There is no history of OCP intake. There was no history of previous surgeries. There is a negative family history. There is no family history of breast cancer or breast hypertrophy. On general examination, conscious and oriented, vitally stable, pallor is present. So this is a clinical photograph of the patient. As we can see, the bilateral breasts have been enlarged and now it has been reaching up till the waistline. And there is also an axillary breast which is also hypertrophic. So because of this bilateral enlargement, she was unable to perform her daily activities. She came actually to our OPD in a stretcher. She is unable to stand up also. And she was looking sick at the time of presentation, but the main complaint was the enlargement of the breast, which has impeded her daily activities and performance. Systemic examination was within normal limits. We have done the workup of the patient. Hemoglobin was 6.4, prolactin was 16.5 nanograms per ml, which is within normal limits. T3, T4, TSH are within normal limits. For every breast lump, we proceed with the triple assessment. So we have got a ultrasound breast, which was impressed on the right breast as possibility of atypical fibroadenoma or phylloids. It's a Bird's-Floor lesion, which is a 2 to 10% chance of malignancy. Left breast is also of the same findings, Bird's-Floor lesion. Then we have advised a MRA breast for the patient, but due to the patient body habitus and because of the large breast, we could not accommodate her in the breast coil. So the study was compromised. So we did only ultrasound breast and a guided biopsies. So the ultrasound guided biopsy is suggestive of benign fibroepithelial lesion consistent with fibroadenoma along with features of pseudoangiomatous stromal hyperplasia. Same findings are seen from the true cuts from both the bilateral breast as well as from the left axillary breast. So our clinical impression: breast fibroadenoma with multiple giant fibroadenomas, breast hypertrophy. So our plan of management was bilateral reduction mammoplasty with nipple areolar complex graft. We have done an inferior pedicle technique. I will explain it in the succeeding slides. So this is the same patient, the intraoperative picture. As you can see on the left side, we have marked the breast. So the key points before you do a reduction mammoplasty is preoperative breast marking. How do we do it? There are ideal breast measurements for it: the distance of the nipple areolar complex from the sternal notch, where to position the inframammary fold, which quadrants of the breast you want to remove, and how to position the new NAC at a new position. So this is the right side. This was a pencil diagram of how we have done the planning in this patient. The distances as well as the key position of the key fold, and this dotted line is the inferior pedicle. So this nipple will come to lie in this position at the end of the surgery. I'll go ahead with the surgical steps. Better to So the left axillary breast, which we have excised and sutured the skin. Now this is the pedicle. This is the pedicle, inferior pedicle. So in this case, we have decided that NAC vascularity will be maintained by the inferior pedicle. So initially we have de-epithelialized it. In the next slide, you can see it was de-epithelialized. The NAC is still on the inferior pedicle, and then superior anteromedial and anterolateral sections of the breast are excised. So the nipple, in this case, then we have harvested a nipple as a skin graft, and once the pedicle as well as the skin flaps are closed, we have put the nipple areola complex as a graft on the breast. This is the post-operative picture. As you can see, the amount of breast excised and the NAC complex was moved to a superior position. Intraoperative findings: right breast tissue, which is filled with fibrous masses, the volume was about 4.8 kilograms, and left axillary breast was 900 grams, and left breast excised, which was about 2.6 kgs. On histopathological examination, the histopathological examination will be discussed by Dr. Pinnakin, senior resident from pathology.
Hello, good morning all. Before going on to the photomicrographs that we saw on microscopy, I would like to explain the normal architecture of breast. These are the terminal ductal lobular units which form a normal breast globule. So this is how a normal breast should look like. But instead what we received was this kind of a picture. As you can see, there is dense pink deposit which is actually collagen, and there is stromal fibrosis, which made us think that it could not be either of phyllodes or fibroadenoma. And as you can see in this pic, there is increased stromal collagen, and there are some slit-like spaces which give the impression of pseudoangiomatous stromal hyperplasia, which was talked about in the biopsy. This one, like these spaces, if they are lined by myofibroblasts, then they give the impression of pseudoangiomatous stromal hyperplasia. And this was another section which showed us accessory breast, which was significant because it could be a site for potential cancer. But in a case of fibroadenoma, what we'll get is we'll get proliferation of these units. These units will be proliferated, and there will be, in case of phyllodes, there will be a stromal hyperplasia, which we did not appreciate. So we came to the diagnosis of gigantomasia.
So the post-operative course was uneventful and patient was discharged on POD5. So these are the pictures taken in the follow-up period. As we can see, the amount of breast tissue has reduced, and it was a cosmetically better looking breast, and it was further planned for fat grafting at a later setting. Macromastia is a developmental increase in the breast volume and weight, and the reduction mammoplasty is indicated for symptomatic relief as well as aesthetic improvement. So the etiology is multifactorial: genetic, obesity, pregnancy, and there are juvenile breast hypertrophy, sometimes tumors of the breast, juvenile fibroadenoma, Phyllodes tumor, juvenile papillomatis, and sometimes it is very rarely associated with Cowden syndrome. But most common thing is these are sporadic cases. There won't be any family history. On evaluation, complete general examination. The local examination is done in the view to address these issues, like how much expected reduction volume we are planning, the nipple areola size, shape, asymmetry, the nipple sensation, right and left nipple to sternal notch distance, and distance to inframammary fold measurement. These are the measurements I will describe in the later slide. This has to be examined in the local examination, so for planning of the surgery. And routine investigations are done. Hormonal profile, serum prolactin, estrogen and progesterone has to be done. And radiology, ultrasound, mammography if greater than 35 years old. Indications for surgery: very large breast causing shoulder pain, cervical or upper thoracic pain, severe embarrassment, recurrent intertrigo, inability to exercise due to breast discomfort. Due to large volume of the breast, patients tend to lie supine and they don't exercise. That again leads to obesity. So many a time the obese patients tends to present with this, and difficulty in breathing. So this is the classification of breast hypertrophy. If the resection volume is less than 200 grams per side, it is mild. Moderate is 200 to 500 grams. Severe resection is 500 to 1500, and gigantic resection greater than 15 grams per side. So there are several techniques described to address the gigantomastia, which has been described as a part of reduction mammoplasty. So several authors have described several different techniques. So the main operative goals too easy to understand. The main operative goals are: how do you maintain the NAC complex vascularity, how do you excise the breast parenchyma, and then the skin envelope reduction and the breast shaping. These are the 4 operative goals. And on the right side, the different techniques to achieve the 4 operative goals, which again differs between each technique. So the NAC complex vascularity, you can maintain it by a superior pedicle, inferior, superior medial, central and vertical bipedicle, which is also McKessock's procedure, horizontal bipedicle. And how do you remove the excess breast parenchyma? It is removal on the pedicle. We remove a horseshoe shaped breast. Basing on that pedicle around it, as seen in the previous photographs, we removed a horseshoe shaped breast centered on the pedicle. And the skin envelope reduction, inverted T-scar pattern and short scar strategies. And breast shaping is done by internal breast flaps, supportive mesh framework or breast shaping maneuvers, or simply skin draping as in this case. So this is the ideal breast measurements which are generally used. How much distance of the nipple area complex, internipple distance, and how much distance of the NAC from the sternal notch and from the mid clavicular gland. These are the meridians which has been drawn, and normal distances, ideal breast measurements of the adult woman. So these are the 4 broadly categorized techniques. The breast reduction with Weiss pattern, inverted T incision, and vertical mammoplasty with a superior pedicle as well as a superior medial pedicle, and a spare mammoplasty, which means short incision, periolara, inferior pedicle, reduction mammoplasty. So I have broadly categorized, and in the boxes you can see the 4 main operative goals in each of the technique. And in the first technique, Weiss pattern inverted T, NAC vascularity is maintained by inferior pedicle, the parenchymal removal superiorly around the pedicle, skin envelope is done by inverted T, and shaping is given by skin draping. In the second, the NAC is maintained by the superior pedicle. In our case, we have taken the NAC complex as a skin graft and then placed it over the breast. In the vertical mammoplasty, the NAC vascularity is by superior pedicle, and parenchymal removal is done inferiorly under the pedicle. Skin envelope is circumvertical, and the shape is given by the pillar plication. In the other variant, the difference is only that the NAC vascularity is maintained by the superior pedicle, and in the spare mammoplasty, the vascularity is from the inferior pedicle, and the skin envelope is circumvertical, but the shape is given by the internal sutures. Learning points: evaluation for malignancy, hormonal imbalance and eating disorders has to be done in all cases of gigantomastia. Reduction mammoplasty is a safe and effective procedure for gigantomastia. Surgical management restores physical and psychological health and returns to the daily activities. Thank you.